Welcome back to the deep dive. Today we are tackling a really big one, the whole world of gastrointestinal, biliary, pancreatic, and nutritional health.
It's a huge unit. Absolutely. A lot to cover.
Exactly. And our mission here is to give you, the learner, a really fast but thorough way to get your head around the key concepts. We're talking pathophysiology, risks, signs, how things are diagnosed, and especially those priority nursing actions.
Across the whole system, really.
Yeah.
And you can't understand the problems without appreciating the system itself. I mean, think about it. This GI tract is a 25-foot-long tube, essential for life, running from, mouth all the way down to the anus.
25 feet? That's amazing, and it's doing so much work.
Constantly. It's got 5 core functions we need to keep in mind: secretion, enzymes, hormones, that sort of thing. Then digestion, breaking food down; absorption, pulling those nutrients in; motility, keeping everything moving; and finally, elimination, getting rid of the waste.
Okay, so let's build on that foundation. That 25-foot tube, it's not just simple pipe, is it? It's got layers.
Right, beautifully engineered. 4 key layers in that inner wall. From the inside out, you've got the mucosa, that's the innermost layer, very specialized cells for secretion and absorption.
Okay.
Then outside that is the submucosa. Think connective tissue, lots of blood vessels, nerves, support layer.
Got it.
Layer 3 is the muscularis. This is where the muscle action is circular and longitudinal smooth muscles. They create those waves,
Right.
peristalsis for motility.
Right. Keeps things moving.
Exactly.
Yeah.
And the final outermost layer is the serosa. It's a tough, protective, connective tissue covering.
And you mentioned absorption. That seems like the step where the rubber really meets the road, getting energy into the body.
Absolutely critical. That's when the digested nutrients move out of the gut and into the bloodstream or lymph system. If absorption fails, well, the whole body feels it. We'll definitely see that when we discuss things like malabsorption later on.
So how do we even start figuring out if something's wrong in this huge system? Assessment, right.
Assessment is everything. And safety starts right there. With a really thorough GI health history, we need the details.
Like what specifically?
Well, what do they typically eat?
Yeah.
Any over-the-counter meds, especially NSAIDs. Supplements, what's their normal bowel routine like? Any history of smoking, alcohol use, previous endoscopies, all crucial pieces of the puzzle.
And pain is so common. How do we assess that effectively?
We need structure. The PQRST mnemonic is really helpful here. P, what provokes it? Q, what's the quality? R, does it radiate? S, severity, usually on a scale. And T, timing. When did it start? How long does it last?
Makes sense. But the physical assessment, there's a specific order for the abdomen, isn't there? Something easily missed.
Oh, absolutely critical. High stakes, even.
Yeah.
You must do inspection first, then auscultation listening. Only then do you move to percussion and palpation.
Why that specific order?
Because if you start poking and prodding first, you can actually change the bowel sounds. You might stimulate activity that wasn't there or mask something important. You need that baseline auscultation first. Get it wrong, and your assessment is compromised from the start.
Okay, inspection, auscultation, then percussion, palpation.
Got it. And speaking of high-stakes assessment, there's a huge safety alert related to palpation.
Yes. This is a stop everything moment. If, during your assessment, you see or feel a bulging, pulsating mass in the abdomen, do not touch it further. Stop palpating immediately.
Why? What could it be?
It strongly suggests an abdominal aortic aneurysm, a AAA. And it might be unstable, potentially about to rupture. Touching it could literally cause a fatal hemorrhage. You notify the provider immediately, no exceptions, life-threatening situation.
Wow. Okay, absolutely critical point. Before we dive into specific disorders, any key screening we should mention? Definitely. Early detection for colorectal cancer is huge. So we emphasize screening tests like the annual high-sensitivity fecal immunochemical test, or FIT, or the older guaiac-based fecal occult blood test, the GFOBT. These look for hidden blood in the stool, often the earliest sign.
Good point. Simple tests, big impact. All right, let's start our journey up top. Oral cavity, esophagus. Seems simple, but problems here can be significant.
They really can. Take stomatitis, just inflammation of the mouth lining. It can be painful, make eating difficult, but what we really watch for are the lesions that could be precancerous.
Precancerous lesions in the mouth.
Yes, primarily 2 types we differentiate. First is leukoplakia. These look like white patches, kind of thickened. They can be benign, but they're considered premalignant, need follow-up.
Okay, white patches, leukoplakia. What's the other one?
The one that raises more red flags is erythroplakia. These are velvety red patches, maybe a bit eroded. They're much more vascular, change faster, and have a significantly higher chance of being malignant, usually squamous cell carcinoma, highly suspicious.
So red is generally more concerning than white here. How do we manage general stomatitis just the inflammation.
Comfort and preventing more irritation are key. That means ramping up oral care maybe every 2 hours. Use a soft toothbrush or even gauze. Avoid anything harsh.
Like alcohol mouthwash.
Definitely no alcohol-based washes, no lemon glycerin swabs, either they can be drying and irritating. Stick to gentle saline rinses. And topical analgesics, maybe a lidocaine solution, can be essential for pain control so the patient can actually eat and drink.
Makes sense. Okay, moving down into the esophagus. GERD, gastroesophageal reflux disease. So common, but potentially serious.
Very common. It's chronic, and it's all about the lower esophageal sphincter, the LES. It's supposed to stay tightly closed, but in GERD, its tone is compromised. It's too relaxed. So stomach contents acid, pepsin flow backward, reflux into the esophagus.
And that damages the esophagus lining.
Exactly. That lining isn't built to handle stomach acid repeatedly. So risk factors often relate to things that either weaken the LES directly or increase pressure in the stomach pushing up against it.
Like being overweight.
Precisely. Increased intra-abdominal pressure from obesity is a major factor. Also, lifestyle choices. Smoking, heavy alcohol use, they directly relax the LES. And infection with H. pylori can play a role too, maybe by slowing down stomach emptying.
What does GERD feel like? What are the symptoms we should look for?
The classic ones are dyspepsia, that's your heartburn, indigestion and regurgitation, feeling that acid creep up. But there are others too.
Like what?
Water brash, suddenly getting a mouthful of saliva, dysphagia, difficulty swallowing. And sometimes, especially in older adults, the symptoms aren't typical GI ones. They might have atypical chest pain or respiratory issues.
Respiratory.
A chronic nighttime cough or persistent hoarseness. That can actually be from tiny amounts of stomach contents being aspirated into the lungs while they sleep. Microaspiration.
That sounds awful. And the really scary long-term risk is Barrett's esophagus, right?
Yes. This is a crucial concept. When the esophagus tries to heal from all that acid damage, the cells can actually change. The normal squamous cells get replaced by tougher, more acid-resistant columnar cells. That new tissue is called Barrett's esophagus.
Why is that bad if it's tougher?
Because that changed tissue, that columnar epithelium, is considered pre-malignant. It significantly increases the risk of developing esophageal adenocarcinoma down the road. So chronic GERD isn't just uncomfortable, it's a cancer risk factor.
So managing GERD focuses a lot on preventing that reflux in the first place, lifestyle changes.
Absolutely. That's the first line. Avoid trigger foods that relax the LES, like peppermint, chocolate, caffeine, fatty foods. Stop smoking, limit alcohol, weight loss if needed. And crucially, positioning.
How so?
Teach patients to elevate the head of their bed, maybe 6 inches, using blocks or a wedge. Not just propping up on pillows, but tilting the whole bed. Gravity helps keep the acid down while they sleep. Don't elevate the foot of the bed that makes it worse.
Good distinction.
Right.
And medication.
Usually a step-up approach. Start with antacids for quick relief. Then H2 blockers, histamine receptor antagonists, to reduce acid production. But the heavy hitters are the proton pump inhibitors, the PPIs.
How do PPIs work?
They basically shut down the acid pumps in the stomach lining. Very effective for healing the esophageal lining. But GERD often comes back if you stop the medication or don't manage the lifestyle factors.
Okay. Now, related to that area near the LES, we have hiatal hernias, stomach pushing up into the chest.
Exactly. The stomach protrudes through the opening in the diaphragm, where the esophagus passes through the esophageal hiatus. There are different types, and the type really dictates the risk.
What's the most common type?
That's the sliding hernia, or type I. The junction between the esophagus and stomach and part of the stomach itself slides up into the chest when the person lies down or strains, and often slides back when they stand up. The main issue with sliding hernias, usually reflux, GERD symptoms again.
But there are other types that are more dangerous.
Yes, the paraesophageal or rolling hernias types the 2nd, 3, and 4. Here, part of the stomach pushes up alongside the esophagus. These are riskier because that herniated part of the stomach can get trapped.
Trapped? What happens then?
Big problems. It can twist on itself, that's volvulus, or its blood supply can get cut off, strangulation. That's a surgical emergency.
Yeah.
So if someone with a known rolling hernia has sudden severe chest or abdominal pain, difficulty swallowing, you have to think strangulation. Surgery is often recommended for these types to prevent that.
So the management really links back to GERD principles for the sliding type, but surgery is more likely for the rolling types due to those high-risk complications. Okay, let's move into the stomach itself. If acid can damage the esophagus, it can certainly damage the stomach lining.
Gastritis, right?
Right. Gastritis is just inflammation of that stomach lining, the mucosa, and it comes in 2 main forms, acute and chronic.
What's the difference? Acute gastritis hits suddenly. Often causes epigastric pain, nausea, maybe some vomiting, usually triggered by something like taking a lot of NSAIDs, drinking too much alcohol, or a major stress event. Good news is, it often resolves quickly once you remove the irritant.
And chronic.
Chronic gastritis is sneakier. It's a patchy, diffuse inflammation that develops over time. The real danger here is that it can lead to atrophy, a thinning of the stomach lining.
Atrophy? Does that cause other problems?
Yes, a major one. It can destroy the parietal cells in the stomach lining. These cells make intrinsic factor.
Intrinsic factor rings a bell. Vitamin B12.
Exactly. You need intrinsic factor to absorb vitamin B12 from your food down in the small intestine. No intrinsic factor means no B12 absorption, which leads to pernicious anemia, a specific type of megaloblastic anemia. So patients with chronic gastritis often end up needing lifelong B12 injections.
Wow, direct link there. What about bleeding with gastritis? How would that show up?
Severe gastritis can definitely bleed. If it's acute upper GI bleeding, you might see hematemesis, vomiting blood. It could be bright red if it's really brisk bleeding, or look like coffee grounds if the blood has sat in the stomach and been partially digested by acid.
Okay, vomiting blood is hematemesis. Any other signs?
The other key sign is melena. This is when the blood passes through the GI tract, gets broken down by bacteria and enzymes, and results in black, sticky, terry-looking stools. Melena indicates the bleeding is likely upper GI or slow bleeding from higher up.
Got it. Hematemesis and melena. Now, related but distinct is peptic ulcer disease, PUD. This is more than just inflammation, it's an actual erosion, right?
Correct. In PUD, the mucosal defenses of the stomach, or duodenum, are broken down, allowing acid and pepsin to literally eat away at the lining, creating an ulcer. Two main culprits are responsible for most PUD.
Let me guess. H. pylori infection.
That's number one. That bacterium, especially strains carrying the CAGA gene, is a major cause. Number two is chronic use of NSAIDs, aspirin, ibuprofen, and naproxen.
How do NSAIDs cause ulcers?
They inhibit prostaglandins. Prostaglandins normally protect the stomach lining by stimulating mucus and bicarbonate segregation and increasing blood flow for repair. Block the prostaglandins with NSAIDs, and you leave the lining vulnerable to acid attack.
Makes sense. What about stress ulcers? Are they the same thing?
They're related but distinct. Stress ulcers are acute lesions that develop rapidly after severe physiological stress. We see curling ulcers in patients with extensive burns thought to be due to reduced blood flow to the stomach, and Cushing ulcers in patients with head injuries, possibly due to overstimulation of the vagus nerve increasing acid production. These are serious, so in critical care, patients often get prophylactic IV PPIs to prevent them.
Okay, now the classic distinction in PUD is between gastric ulcers and duodenal ulcers. How do they differ clinically?
It's a key comparison. For gastric ulcers, think older patient, often malnourished. The ulcer is usually in the stomach itself. And the key pain pattern. Pain typically gets worse shortly after eating, as food stimulates acid release right onto the ulcer.
Worse with food for gastric. What about duodenal?
Duodenal ulcers tend to occur in younger patients, often well-nourished. The ulcers in the first part of the small intestine, the duodenum. Their pain pattern is often the opposite. Pain gets better with eating because the food buffers the acid reaching the duodenum.
Better with food, but doesn't it come back?
Yes, that's the other classic sign. Pain often wakes them up at night, usually a few hours after eating, like 1 to 3 a.m., when the stomach is empty and acid secretion peaks without any food buffer.
That's a very clear distinction. How is PUD diagnosed for sure?
The gold standard is an EGD esophagogastroduodenoscopy. Scope allows direct visualization, can biopsy the ulcer to check for malignancy, and test for H. pylori.
And if H. pylori is found, what's the treatment?
Eradication is the goal. Standard treatment is usually triple therapy, a PPI plus 2 antibiotics, commonly clarithromycin and amoxicillin, or maybe metronidazole, typically for 10 to 14 days. Compliance is key.
Let's circle back to diet for a sec. We often tell PED patients to avoid caffeine, but you mentioned decaf coffee is also a no-go. Why?
Yeah, that surprises people. It's not just the caffeine. Coffee, both regular and decaf, contains peptides that actually stimulate gastrin release. Gastrin is the hormone that tells the stomach to produce more acid, so both need to be avoided. Also, avoid eating right before bed. That stimulates nighttime acid production too.
Good point. Okay, worst case scenario. The ulcer bleeds significantly. What's the immediate priority?
Critical rescue time. Think ABCs. Airway, Breathing, circulation. For circulation, you need immediate supportive care. Get oxygen on them. Start 2 large-bore IV lines right away, 18 gauge or bigger if possible. You need access for rapid fluid resuscitation, potentially blood products.
And monitoring.
Vitals every 5-15 minutes initially.
Yeah.
Watch for tachycardia, hypotension, changes in mental status, signs of hypovolemic shock. This is a true emergency.
Absolutely. One last thing on stomach issues. After some types of stomach surgery, like a partial gastrectomy, patients can develop dumping syndrome. What is that?
Dumping syndrome is rough. It's a group of vasomotor symptoms. Think dizziness, rapid heart rate, tachycardia, feeling faint, syncope, sweating, pallor. It happens quickly, usually within 30 minutes after eating.
What causes it?
It's due to the rapid emptying of hyperosmolar food contents from the smaller stuff pouch directly into the small intestine. This super concentrated stuff pulls a large volume of fluid from the bloodstream into the gut lumen very quickly. That causes the abdominal distension and cramping, and the fluid shift causes the systemic symptoms.
How do you manage that? Mostly diet?
Yes, dietary management is key. Small, frequent meals. Higher in protein and fat, lower in carbs. And importantly, avoid drinking liquids with meals. Drink them between meals instead. Lying down for a short time after eating can sometimes help slow the emptying too.
Okay, let's follow the flow down into the intestines now. First up, intestinal obstruction, a complete blockage. Sounds serious.
It's very serious. Needs prompt attention. We basically categorize obstructions into 2 types, mechanical and non-mechanical.
Mechanical means a physical blockage.
Exactly. Something is physically blocking the lumen. Most common cause after surgery is adhesion scar tissue. But it could be tumors, impacted feces, intussusception, where the bowel telescopes into itself, or volvulus, a twisting of the bowel.
And non-mechanical.
That's usually paralytic ileus. The bowel isn't physically blocked, but peristalsis, the muscle movement stops. The nerves or muscles just aren't working. We often see this temporarily after abdominal surgery or with electrolyte imbalances or certain medications.
What does a complete obstruction look like clinically? What symptoms would you see?
Typically, mid-abdominal cramping pain comes in waves initially. Vomiting is common if it's a high obstruction in the small bowel. The vomit might be bile-stained. If it's lower down, like the ileum, the vomiting starts later, can be profuse and really foul-smelling, almost like fecal matter.
That sounds awful. What about bowel movements?
With a complete obstruction, the hallmark is obstipation. The patient can't pass any stool or even gas, flatus. That's a key sign. Also, sigultus, hiccups, are surprisingly common due to irritation of the phrenic nerve.
It's interesting. What about bowel sounds? What would you hear?
In early mechanical obstruction, the bowel is trying really hard to push past the blockage. So, proximal to the obstruction, you might hear high-pitched, tinkling, rushing sounds called borborygmy. But as the bowel gets tired, or if it's a paralytic ileus, the sounds become hypoactive, diminished, and eventually completely absent. Absent sounds are a worrying sign.
So how do we manage an obstruction initially?
Priority 1 is rest the bowel. Make the patient NPO nothing by mouth. An NG tube, nasogastric tube, is usually inserted and put to suction. This decompresses the stomach and bowel above the obstruction, relieving distension and reducing vomiting.
What else?
Finding fluids are critical to replace lost fluids and electrolytes from vomiting and fluid shifting to the bowel. Pain management, of course. And positioning the patient in semifowlers can help with breathing, as the distended abdomen won't push up on the diaphragm as much.
When does it become a surgical emergency?
The big fear is strangulation. This means the blood supply to the obstructed loop of bowel gets cut off, usually due to twisting or severe compression. That bowel tissue becomes ischemic, then necrotic. It dies. This can lead to perforation, peritonitis, sepsis. It's life-threatening.
What are the signs of strangulation?
Look for worsening pain, maybe becoming more localized and constant, fever, tachycardia, abdominal rigidity, or tenderness. Any suspicion of strangulation means immediate surgical intervention is needed.
Got it. Okay, related issue. Hernias, bowel poking through a weak spot.
That's the basic idea. A protrusion of bowel or other tissue through a weakness in the abdominal wall. We classify them based on whether they can be pushed back in.
So what are the classifications?
A reducible hernia is one where you can gently push the bulge back into the abdominal cavity. An irreducible or incarcerated hernia cannot be pushed back. This is more concerning because it means the bowel might be trapped. It needs close monitoring, likely surgery soon.
And the most dangerous.
That's the strangulated hernia. Same concept as with obstruction. The blood supply to the herniated bowel is cut off. Tissue ischemia, necrosis. This is a critical safety priority, an absolute surgical emergency. Pain, tenderness, maybe nausea and vomiting.
When surgery's done, a herniorrhaphy or hernioplasty, often minimally invasive. Now, what's the key teaching afterwards?
Avoid increasing intra-abdominal pressure for several weeks. That means no heavy lifting, pushing, pulling, and absolutely crucial, prevents straining during bowel movements. They'll likely need stool softeners to keep stools soft and easy to pass so they don't put tension on that surgical repair.
Makes perfect sense. Okay, let's shift to the large bowel and talk about colorectal cancer, CRC, risk factors, beyond family history.
Lifestyle plays a huge role. Diets low in fiber but high in animal fat and refined carbs are strongly linked. Also, obesity, smoking, heavy alcohol use, and having a history of chronic inflammatory bowel disease, like ulcerative colitis, significantly increases risk over time.
The tricky part is that CRC often doesn't cause symptoms early on, right?
Exactly. Early stages are often silent. By the time symptoms appear, the disease might be more advanced. We look for things like a persistent change in bowel habits, constipation, or diarrhea that's new, a change in the shape or caliber of the stool, like becoming pencil thin, unexplained weight loss, and fatigue, often due to chronic, slow blood loss causing iron deficiency anemia.
We mentioned the stool tests like FIT for screening. Remind us about the prep for those.
Right. For the guaiac-based FOBT or the AFIT, patients usually need to avoid certain things for about 48 hours beforehand to prevent false positives. That includes aspirin, NSAIs, vitamin C, iron supplements, and red meat.
Okay. And there's a blood test, CEA.
Carcinoembryonic antigen, CEA. It's not really used for initial screening because it's not specific enough. An AP resection is a big surgery. It removes the sigmoid colon, the rectum, and the anus. Because the anus is removed, the patient will have a permanent colostomy created on the abdomen for stool elimination.
Okay, colostomy care. What should the stoma look like right after surgery?
The stoma, the part of the intestine brought out to the skin, should look healthy. Think beefy red or reddish pink, and moist, not pale, not dark purple or black. Those are signs of poor blood supply.
And the output, does it vary?
Absolutely. It depends entirely on where the colostomy is located along the colon. If it's in the ascending colon, the output will be liquid because little water has been absorbed yet. Transverse colon, it's usually pasty or semi-formed. Descending or sigmoid colon, the stool will be much more formed, similar to a normal bowel movement because most water has been absorbed by then.
Adjusting to an ostomy must be tough psychologically. What about managing things like gas and odor?
Huge psychosocial impact, yes. Odor control is a major concern. Good pouching systems have filters. Patients can use pouch deodorizers. Some even find placing a breath mint inside the pouch helps. But here's a critical safety warning. Never put an aspirin tablet in the pouch.
Why not aspirin?
The acidic nature of aspirin, combined with the digestive enzymes in the stool, can cause severe irritation, ulceration, or bleeding of the stoma itself. Very dangerous. Stick to approved deodorants.
Wood warning. What about the other wound from an AP resection?
Yes, the perineal wound. This is where the rectum and anus were removed. It's often overlooked because everyone focuses on the stoma. But this wound can be very large, deep, and incredibly slow to heal. We're talking potentially 6 to 8 months.
Wow, that long.
Yes, it requires meticulous wound care. Packing, dressing changes, maybe wound vacs, high risk for infection or abscess. It's often more painful and problematic for the patient than the abdominal incision or the stoma in the long run. Needs careful management and lots of patient education.
Okay, now let's dive into inflammation, starting with a really dangerous one, peritonitis, infection of the abdominal cavity lining.
Exactly. Peritonitis is life-threatening inflammation, usually caused by infection, spreading throughout the peritoneum, the membrane lining the abdominal cavity. Most often, it's because something ruptured or perforated appendix, diverticulum, ulcer-spilling bacteria, or chemical irritants into that normally sterile space.
What happens then physiologically?
It triggers a massive inflammatory response. The body tries to wall off the infection, but often fails. Peristalsis slows way down or stops completely paralytic ileus again. And huge amounts of fluid shift from the bloodstream into the peritoneal cavity third spacing. We're talking liters, like 7 or 8 liters a day potentially.
That much fluid loss sounds like shock territory.
Absolutely. Leads to severe hypovolemia, electrolyte imbalances, and often septic shock. It's a critical situation.
What are the absolute telltale signs, the cardinal signs of peritonitis?
3 big ones: severe abdominal pain, generalized tenderness, often with rebound tenderness, and abdominal distension due to the fluid and gas. The abdomen might feel rigid, like a board, and bowel sounds, usually diminished or completely absent because of the ileus.
If surgery is done to fix the source, what's a key post-op nursing action?
Positioning is crucial. Keep the patient in a semi-Fowler's position. This helps in two ways. Gravity helps drain any infected fluid down towards the pelvis, potentially localizing infection, and it takes pressure off the diaphragm, making breathing easier. Also, monitor vitals and mental status relentlessly for signs of worsening sepsis or shock fever, increasing fluid needs, tachycardia, confusion.
Okay, now for the chronic inflammatory conditions, inflammatory bowel disease, IBD. We need to clearly separate ulcerative colitis, UC, and Crohn's disease, CD. Let's start with UC.
Right. Ulcerative colitis is inflammation, but it's generally limited to the colon and rectum. And it only affects the inner layers, the mucosa and submucosa. It almost always starts in the rectum and spreads continuously upwards proximally.
What's the classic symptom of UC?
Frequent bloody diarrhea. Often 10 to 20 liquid bloody stools per day during a flare-up. Patients also often have tenesmus, that feeling of constantly needing to defecate, even if the bowel is empty. Urgency is intense.
What are the major risks or complications with UC?
Two big ones. Toxic megacolon, where the inflamed colon dilates massively and basically becomes paralyzed, a surgical emergency, and a significantly increased risk of colorectal cancer, especially after having the disease for 10 years or more. That's why regular colonoscopy screening is vital for UC patients.
Okay, so UC colon rectum only, superficial layers, bloody diarrhea, cancer risk. How does Crohn's differ?
Crohn's disease is different in several key ways. First, it can affect any part of the GI tract, from mouth to anus, although it most commonly involves the end of the small intestine, ileum, and the beginning of the colon. Second, the inflammation is transmural. It goes through the entire thickness of the bowel wall.
Transmural. Does that cause different symptoms or complications?
Yes. Because it affects the whole wall, Crohn's often causes deep ulcers, scarring, and fibrosis. This can give the inside of the bowel a cobblestone appearance. The stools are typically different too, usually fewer, maybe 5-6 soft, loose stools a day, and classically non-bloody, though bleeding can occur.
And complications unique to Crohn's.
Fistulas are very common. These are abnormal tunnels connecting the bowel to other organs like the bladder or vagina, or even out to the skin. Very difficult to manage. Also, because Crohn's often affects the small intestine, where nutrients are absorbed, severe malabsorption and malnutrition are major problems. Weight loss is common.
So Crohn's, anywhere in GI tract, full thickness, non-bloody stool usually, fistulas, malabsorption, surgery.
Surgery is common in Crohn's. Maybe 75% of patients eventually need it, often to remove disease segments or fix strictures. But unlike UC, where removing the colon can be curative, surgery is not curative for Crohn's. The disease often recurs in other areas.
How are they managed medically? Similarities?
Yes, quite a bit of overlap. Both require trigger avoidance, stress management, avoiding GI stimulants like caffeine, alcohol, sometimes high-fiber foods during flares. Emotional support is huge due to the chronic nature and impact on life.
And medications.
Drug therapy often involves a step-up approach. Aminosalicylates, like mesalamine, are often first line for mild to moderate inflammation, especially in UC. Glucocorticoids, steroids, are used for acute flare-ups, but not long-term due to side effects. Then you have immunomodulators and the powerful biologics.
Biologics like
Agents like infliximab, adalimumab, these target specific inflammatory proteins like tumor necrosis factor, TNF. They can be very effective for inducing and maintaining remission in moderate to severe IBD, but they also suppress the immune system, increasing infection risk.
if someone with UC needs their colon removed, a colectomy, they'll get an ileostomy. What's the output like initially?
Right after surgery, the ileostomy output is typically very loose, almost liquid, dark green, and might have a little blood mixed in. It's continuous because there's no colon to store it.
Does that change?
Yes, definitely. Over weeks to months, the remaining small intestine, the ileum, starts to adapt. It gets better at absorbing water and electrolytes, so the output gradually becomes thicker, more paste-like, the color changes to yellowish-green or brown, and importantly, the odor becomes much less noticeable, often minimal, because fewer bacteria are present compared to the colon.
What's the absolute top priority for ileostomy care?
Skin protection. That ileostomy output is rich in digestive enzymes and bile salts. It's incredibly caustic to the skin. Even brief contact can cause severe irritation and breakdown. So maintaining a good seal with the skin barrier, wafer, and meticulous peristomal skincare is paramount. Constant vigilance.
Got it. Lastly, in this section, diverticular disease. We have diverticulosis and diverticulitis. What's the difference?
Diverticulosis just means having the outpouchings, the diverticula, usually in the sigmoid colon. Most people with allogosis are asymptomatic. Diverticulitis is when one or more of those pouches becomes inflamed or infected, usually because a piece of undigested food or bacteria gets trapped in there.
And diverticulitis causes symptoms.
Yes. Usually abdominal pain, typically in the left lower quadrant, low-grade fever, maybe nausea, change in bowel habits, often constipation, sometimes diarrhea. It can range from mild to severe, with complications like abscess or perforation.
The key teaching point often revolves around diet, and it seems contradictory. Can you clarify?
Absolutely. This is a classic point of confusion. For chronic asymptomatic diverticulosis, the goal is prevention. So you want a high-fiber diet. Fiber adds bulk, keeps stool moving, and theoretically reduces pressure inside the colon, maybe preventing pouch formation or trapping of stool.
High fiber furrosis. What about during an acute argatus attack?
Complete opposite. During acute diverticulitis, the bowel is inflamed and needs to rest. So the diet is initially low fiber or even clear liquids only. Let the inflammation calm down. Once resolved, you gradually reintroduce fiber.
That's a crucial distinction. Anything else to avoid during diverticulitis?
Yes. Avoid anything that increases intra-abdominal pressure. No straining, heavy lifting, and importantly, no laxatives or enemas during an acute attack that could increase pressure and risk perforating an inflamed diverticulum.
All right, let's shift focus to the accessory organs, liver, gallbladder, pancreas, starting with the liver and cirrhosis. This isn't just inflammation, it's scarring, right?
Exactly. Cirrhosis is extensive, irreversible scarring of the liver. Healthy liver tissue gets replaced by fibrotic scar tissue, which disrupts liver structure and, critically, function. It impairs cellular regulation and eventually leads to liver failure.
What causes that scarring?
Historically, the big ones were chronic alcoholism, that's Lennox cirrhosis, and chronic viral hepatitis,
Mm.
especially hepatitis C and B. Hep C used to be the leading cause for liver transplants in the U.S.
Used to be. What's rising now?
Non-alcoholic fatty liver disease, or NAFLD, sometimes called NASH when there's inflammation. This is booming, tightly linked to our modern epidemic of obesity, metabolic syndrome, and type 2 diabetes.
Yep.
Fat infiltrates the liver, causes inflammation, then scarring, then cirrhosis. It's a huge growing problem.
When the liver scarring gets bad enough, we talk about decompensated cirrhosis. What complications does that involve? First one is portal hypertension.
Right, the scarring obstructs blood flow through the liver. Blood coming from the intestines and spleen via the portal vein can't get through easily. So pressure builds up in that portal system. That's portal hypertension.
What does that increased pressure cause?
It forces blood to back up. It backs up into the spleen, causing it to enlarge splenomegaly. It also forces blood into smaller collateral veins that aren't designed for high pressure. Veins in the esophagus, stomach, rectum swell up.
Like esophageal varices.
Exactly. Esophageal varices are dangerously dilated veins in the esophagus. They're fragile and can rupture easily, causing massive, life-threatening bleeding. Portal hypertension is also the primary driver behind ascites.
Ascites the fluid in the abdomen. How does portal hypertension cause that? It seems like there's more to it.
There is. It's a double whammy. First, the high pressure in the portal veins, increased hydrostatic pressure, physically pushes fluid out of the capillaries and into the peritoneal cavity. Second, the failing liver can't produce enough albumin.
Albumin, that holds fluid in the vessels, right?
Correct. Albumin maintains colloid osmotic pressure, or oncotic pressure, in the bloodstream, pulling fluid in. With low albumin, there's less force holding fluid inside the vessels, so you have high pressure pushing fluid out and low pressure failing to pull it back in. Result: massive fluid shift into the abdomen ascites, and often peripheral edema too.
So the patient can be overloaded with fluid in their belly and legs, but actually be dehydrated intravascularly.
Precisely that paradox. They can have profound ascites and edema, yet be hypovolemic centrally with low blood pressure. It makes fluid management incredibly tricky.
Another major complication is hepatic encephalopathy, HE, cognitive changes. What's going on there?
HE is basically brain dysfunction caused by the liver's inability to detoxify substances from the gut. The main culprit is ammonia.
Ammonia. Where does that come from?
It's a byproduct of protein breakdown by bacteria in the intestines. Normally, the portal vein carries this ammonia-rich blood to the liver, which converts it to urea for excretion by the kidneys. But in cirrhosis, blood bypasses the scarred liver, or the liver function is too poor. So ammonia levels rise in the systemic circulation, cross the blood-brain barrier, and act as a neurotoxin.
What are the signs of HE?
It ranges from subtle changes in personality or sleep patterns to severe confusion, coma. Two classic physical signs are asterixis, the liver flap, a flapping tremor of the hands when the wrists are extended, and fetor hepaticus, a distinctive sweet, musty odor on the breath caused by metabolic byproducts the liver can't clear.
How do we manage HE? Lower the ammonia?
That's the goal. The mainstay drug is lactulose. It's an osmotic laxative, but its main action in HE is to lower colonic pH. This traps ammonia in the gut as ammonium ion, NH4+, which isn't absorbed, and promotes its excretion in the frequent stools it causes. We titrate the dose to get 2-3 soft stools a day.
Any other strategies?
Sometimes non-absorbable antibiotics like rifaximin or neomycin are used. They reduce the population of ammonia-producing bacteria in the gut. Diet is also adjusted moderate protein intake, sufficient carbs for energy to prevent muscle breakdown.
If ascites gets really bad, a paracentesis might be done to remove fluid. What's the crucial nursing safety step before that procedure?
Absolutely essential. Have the patient void immediately before the procedure, empty the bladder completely. This reduces the risk of accidentally puncturing the bladder with a needle during the fluid removal. Critical safety check.
Good point. Okay, briefly on hepatitis liver inflammation, the viral types A, B, C, D, E. Key differences in transmission.
A and E are typically fecal-oral route, contaminated food or water. Usually acute infections, though E can be worse in pregnancy. B, C, and D are blood-borne body fluid transmission needles, sex, perinatal.
Which ones cause chronic problems?
B and C are the big ones for chronic infection. Chronic hep B and especially chronic hep C are major causes of cirrhosis and liver cancer globally. Hep D is quirky. It only infects people who already have hep B.
What are the general symptoms of acute hepatitis?
Often vague, initially flu-like symptoms. Fatigue, maybe joint pain, arthralgia, muscle pain, myalgia, nausea, loss of appetite, anorexia. Then, as liver inflammation worsens, jaundice, yellowing of skinnies can appear. Urine might get dark, stools might become light or clay-colored because bile flow is blocked within the liver.
What's the nursing priority for hepatitis?
Rest the liver. Supportive care. Encourage rest. Adequate nutrition, often small, frequent meals due to nausea. Absolutely crucial. Teach prevention of transmission. Good hygiene for AE, safe sex needle practices for BCD, and strict avoidance of anything that could further harm the liver, especially alcohol and acetaminophen, Tylenol, which is very hepatotoxic in high doses or with existing liver disease.
Okay, moving next door to the gallbladder and pancreas. Cholecystitis, gallbladder inflammation, usually caused by gallstones, right?
Most commonly, yes. That's calculus cholecystitis. A gallstone, a calculus, gets lodged in the cystic duct, which drains the gallbladder. Bile can't get out, it backs up, gets concentrated, irritates the gallbladder wall, causes inflammation, swelling, and often pain. Sometimes ischemia, too.
Can you get cholecystitis without stones?
Yes, that's a calculus cholecystitis. Less common, often seen in critically ill patients, perhaps due to bile stasis, ischemia, or infection. Interestingly, a chronic form can sometimes occur in people on very low-fat diets, maybe because the gallbladder isn't stimulated to contract and empty regularly.
What triggers the pain typically?
The classic trigger is eating a fatty meal. Fat stimulates the release of cholecystokinin, CCK, a hormone that tells the gallbladder to contract and squirt bile into the duodenum to help digest the fat. If the duct is blocked by a stone, that contraction against resistance causes intense pain, usually in the right upper quadrant, sometimes radiating to the right shoulder or back.
What if the blockage persists? Can other symptoms develop?
If the inflammation is chronic or the blockage severe, you might see signs related to lack of bile reaching the intestine, jaundice, if the common bile duct gets involved, dark amber urine, and steatorrhea, fatty, greasy, foul-smelling stools because fats aren't being digested properly without bile. Also, deficiencies in fat-soluble vitamins, A, D, K, can occur over time.
How is it usually diagnosed?
The best initial test is usually an abdominal ultrasound. It's great at visualizing gallstones and gallbladder wall thickening. A HIA scan, hepatobiliary immunodiacetic acid scan, can also be used. It assesses the function of the gallbladder and the patency of the biliary ducts.
And the treatment? Usually surgery.
The gold standard treatment now is laparoscopic cholecystectomy, removing the gallbladder through small incisions. LapChol. It's minimally invasive, recovery is much faster than open surgery, lower risk. Most patients go home the same day or the next.
Do they need a special diet after gallbladder removal?
Generally, no strict long-term diet is required. The liver still makes bile, it just drips continuously into the intestine instead of being stored. Some people find they initially have some loose stools or discomfort after very high-fat meals, so they might need to moderate fat intake initially, but most adapt well over time.
Okay. Now for the pancreas. Acute pancreatitis. You said this one is serious, potentially life-threatening. What's happening inside?
It's a cascade of destruction. The core problem is the premature activation of powerful pancreatic digestive enzymes like trypsin, lipase, while they're still inside the pancreas. Normally, they're inactive until they reach the duodenum.
So pancreas starts digesting itself.
Exactly. Autodigestion. It's horrific. This process involves several things happening at once. Lipolysis enzymes break down fat cells in and around the pancreas. Proteolysis enzymes break down proteins, including the tissue of the pancreas itself and blood vessel walls. Necrosis of blood vessels leads to bleeding, sometimes massive hemorrhage into the abdomen or retroperitoneum, and intense inflammation throughout.
What usually triggers this premature activation?
The two most common causes are heavy alcohol use and gallstones getting stuck down near the end of the common bile duct, blocking pancreatic outflow. Other causes exist, but those are the big two.
What does the patient look like? The pain?
The pain is typically severe, constant, boring pain, often in the epigastric area, frequently radiating straight through to the back. It often starts suddenly, maybe after drinking alcohol or eating a large fatty meal. Nausea and vomiting are very common. They look sick. May have fever, tachycardia, hypotension if it's severe.
Any other signs? Jaundice, blood sugar issues.
Jaundice can occur if the swollen head of the pancreas compresses the common bile duct. And because the pancreas also produces insulin, damage to the islet cells can cause hyperglycemia, sometimes requiring insulin temporarily.
What about managing that severe pain beyond opioids?
Opioids, often via PCA pump, are essential. But positioning can help too. Patients often find relief by lying on their side with their knees drawn up towards their chest, the fetal position. It seems to decrease stretching of the abdominal muscles and peritoneum.
And what is the absolute #1 GI priority for acute pancreatitis?
Rest the pancreas completely. That means NPO, absolutely nothing by mouth, no food, no water, no ice chips. Any stimulation of the GI tract can trigger more enzyme release. So NPO status is immediate and non-negotiable until the inflammation starts to resolve.
If they have to be NPO for a while, how do they get nutrition? TPN.
That used to be the standard, but thinking has shifted. If the patient can't eat for more than, say, 24, 48 hours, early enteral nutrition is now preferred over TPN, if possible.
Enteral. How if they're NPO?
Usually via a feeding tube placed into the jejunum past the duodenum, an anasojunal NJ tube, or a surgically placed jejunostomy J tube. Feeding directly into the jejunum bypasses the stomach and duodenum, minimizing pancreatic stimulation.
Why is enteral preferred over TPN now?
Several reasons. It helps maintain the gut barrier integrity, prevents bacterial translocation, leaky gut, supports the immune system better, and generally has fewer complications, especially infectious and metabolic ones, compared to TPN. So if the gut works, use it. Even in pancreatitis, just feed downstream.
Okay, let's wrap up our deep dive by looking at the bigger picture of nutrition, both undernutrition and obesity.
So fundamental. Nutritional status impacts healing, recovery, everything. That's why hospitals mandate a nutrition screening, usually within 24 hours of admission for all patients.
And when we're tracking fluid status, especially in GI patients with fluid shifts or losses, what's the most reliable measure?
Accurate daily weights. Weigh the patient at the same time each day, same scale, same amount of clothing. It's the single best indicator of overall fluid gain or loss, better than intake and output records alone sometimes. BMI is useful too, of course, normal range, 18.5 to 24.9.
When someone is undernourished, are there specific types we should recognize?
Yes, protein energy undernutrition, or PEU, has a few forms. Marasmus is basically calorie starvation. The patient loses significant body fat and muscle mass, looks emaciated. Kwashiorkor is primarily protein deficiency, even if calorie intake is okay. Classically presents with edema, often in children in famine areas, but we see it in hospitalized patients too. And marasmic kwashiorkor is a mix of both.
Is there a hidden risk for undernutrition, especially in older adults?
Definitely. Unrecognized dysphagia, difficulty swallowing. It's common in the elderly, especially after stroke or with neurological conditions. If they can't swallow safely or effectively, they don't eat or drink enough, leading to undernutrition, dehydration. And critically, it massively increases the risk of aspiration pneumonia. Always assess swallowing function if you suspect it.
If someone can't eat enough orally, we might need total enteral nutrition, 10N, tube feeding. What kinds of tubes are used?
For short-term feeding, less than 4 weeks usually, we use nasoenteric tubes, NG, nasogastric, ND, nasoduodenal, NJ, nasogenuinal. For long-term feeding, we prefer enterostomal tubes placed directly through the abdominal wall like a PEG, percutaneous endoscopic gastrostomy, or a jejunostomy, J-tube.
And how is the feeding given? All at once?
Different methods. Bolus feeding is giving larger amounts intermittently, like mimicking meals. Continuous feeding runs slowly via a pump over many hours or 24 hours. Cyclic feeding runs continuously for a portion of the day or night, maybe 12, 18 hours, then stopped for a period to allow more freedom.
Okay, tube safety. This is huge. How do we confirm a newly inserted feeding tube is in the right place?
This is a massive patient safety issue, and practice has changed. The absolute most accurate method, the gold standard for initial placement verification, is X-ray confirmation, period.
Not listening for air or checking pH.
No. Those methods are unreliable and potentially dangerous. Auscultating an air bolus whoosh sound does not confirm placement. You can hear that even if the tube's in the lung or esophagus. pH testing can be helpful as an adjunct later to check ongoing placement, but it's not reliable enough initially, especially if the patient is on acid-suppressing meds. X-ray is mandatory first. If there's any doubt, or if you suspect a tube has become dislodged, stop the feeding immediately and get confirmation.
Crucial point. How do we prevent tubes from getting clogged? That's a common frustration.
Prevention is key. Flush the tube regularly with water, usually 30 milliliter at least every 4 hours during continuous feeds, and always before and after giving medications or checking residuals. Use liquid medications whenever possible. Crushed tablets are notorious for clogging. Never mix medications directly with the formula in the bag. Use a large enough syringe, 30 ml or 60 ml for flushing, to avoid excess pressure.
Got it. Flush, flush, flush. Now, a really scary complication, refeeding syndrome. What is that?
It's a potentially fatal metabolic emergency that can happen when you start feeding severely malnourished patients too quickly, whether enterally or parenterally.
What happens metabolically?
When you suddenly give carbohydrates, glucose, to someone who's been starving and primarily using fat ketones for energy, their body switches back to carb metabolism. This process requires large amounts of intracellular electrolytes, especially phosphate, potassium, and magnesium. Insulin surges, driving these electrolytes from the blood into the cells very rapidly.
So blood levels plummet.
Exactly. You get profound hypophosphatemia, hypokalemia, and hypomagnesemia. This electrolyte depletion causes the clinical signs: heart failure due to lack of phosphate for ATP energy, respiratory failure, muscle weakness, confusion, seizures, edema.
How do we prevent or manage it?
Start low, go slow. Begin nutritional support at a very low rate for severely malnourished patients and increase gradually over several days. Monitor electrolytes, especially phosphate and potassium, very closely before and during the first few days of feeding. Replete electrolytes aggressively as needed. It's a critical rescue situation requiring vigilance.
Wow. Okay, finally, obesity. We know the BMI classifications, 30 plus. Why is waist circumference also so important?
Obesity is more than just weight. It's an active metabolic condition. Adipose tissue releases adipokines, hormones that influence appetite, inflammation, insulin resistance. While BMI gives an overall measure, waist circumference specifically indicates visceral fat, the fat around the internal organs.
And visceral fat is the dangerous kind.
Yes, high visceral fat indicated by waist circumference over 35 inches in women or 40 inches in men is a stronger predictor of risks like coronary artery disease, type 2 diabetes, and metabolic syndrome than BMI alone. It tells you more about metabolic risk.
When managing obesity, is dramatic weight loss always the goal?
Not necessarily initially. Even a modest weight loss, like 5% to 10% of initial body weight, can significantly improve health outcomes. Lower blood pressure, better glucose control, improved lipids. Sustainable lifestyle changes are key.
What does non-surgical management involve?
A combination approach: dietary changes, calorie reduction, balanced nutrition, increased physical activity, even starting with 20 minutes of walking daily helps. Behavior modification, sometimes medications approved for weight loss. It's about long-term habits.
And bariatric surgery, who's a candidate?
Generally, patients with a BMI of 40 or higher, or a BMI of 35 or higher, with significant obesity-related comorbidities like diabetes, severe sleep apnea, heart disease. But surgery isn't a magic bullet.
What's required of the patient?
They must be committed to major, permanent lifestyle changes, adhering to specific dietary restrictions, small portions, food choices, regular exercise, and crucially, lifelong vitamin and mineral supplementation, because many procedures cause malabsorption. It's a tool, not a cure, and requires intense patient commitment. Common restricted procedures include the sleeve gastrectomy, where much of the stomach is removed, or adjustable gastric banding.
Wow. We have covered an immense amount of ground today, journeying all the way through the GI tract and its crucial accessory organs.
We really have. For the basic structure and function, that critical assessment order: inspect, auscultate, percussus, palpate, and that vital AAA warning.
Right, don't palpate a pulsating mass. Then up top, GERD and the Barrett's risk, the different pain patterns for gastric versus duodenal ulcers, and managing H. pylori.
Down into the bowel, understanding obstructions, hernias, the differences between reducible, incarcerated, and strangulated. colorectal cancer screening and stomach care, especially that tricky AP resection wound.
And those inflammatory conditions, the cardinal signs of peritonitis, and really nailing the distinctions between UC, bloody colon only, and Crohn's, transmural fistulas malabsorption, plus that key diet switch for diverticulosis versus diverticulitis.
Then the accessory organs. Cirrhosis complications like portal hypertension causing varices and ascites, the ammonia issue in HE needing lactulose, hepatitis risks, gallstones triggering cholecystitis pain, and that dangerous autodigestion and pancreatitis requiring immediate NPO status.
And finally, tying it all together with nutrition, the risks of undernutrition and dysphagia, the absolute necessity of X-ray confirmation for feeding tubes, and the potentially lethal refeeding syndrome, plus understanding obesity beyond just BMI.
Absolutely. If you look back, the common threads weaving through almost every condition are the nursing priorities. Managing pain effectively, ensuring safe and appropriate nutrition, maintaining that delicate fluid and electrolyte balance, and promoting safe elimination.
It really highlights how interconnected everything is. A problem in one spot can have system-wide consequences. Considering the sharp rise we're seeing in conditions like NAFLD directly linked to lifestyle and the ongoing burden of chronic inflammatory diseases, it makes you think.
It really is.
Will the focus in nursing need to shift even more dramatically in the coming years, moving beyond just managing the acute crises, the bleeding ulcer, the pancreatitis flare, the obstruction towards a much stronger emphasis on primary prevention, focusing on nutrition, lifestyle counseling, early screening, trying to head off these devastating GI problems before they even start? Something important for all of us, especially you, the learner, to consider as you take this knowledge forward.